to everybody, and thank you very much for the invitation. My name is Chiara Robba, and I work in Italy, in Genova at Policlinico San Martino. I'm delighted to be here, even if just virtually, and to discuss with you one of the most important topics, I think, in neurocritical care, which is the fluid management in this controversial group of patients. I have no conflict of interest regarding this presentation. This is the table of contents that we are going to discuss in the next minutes. So we are going to start with a bit of pathophysiology and discussing why we need, what do we need the fluids to do in neurocritical care patients. And then we are going to discuss general and specific indications regarding the type of fluids and the clinical application of fluids in neurocritical care. So the role of fluids in neurocritical care. As we know, the water is able to pass through the intra to the extravascular status through the blood-brain barrier, which is enable to the water to pass, but does not able to micromolecules like sodium, etc., to pass through from the intra to the extravascular space. And this is something which is called basically osmotic gradient. So this is how particles are shifted from the intra to the extravascular space when the brain-blood barrier is integral. So the osmotic gradient leads basically to two main but very important principles. The first one is that any subject with a normal plasma osmolarity will not reduce his brain water content as a consequence of the dehydration. And the second one is that the osmolar gradients can move water from the tissue towards the plasma compartment. So these are the two main mechanisms. And in fact, when the cerebral autoregulation is intact, what is depending, what causes and determines the cerebral blood flow is not the cardiac output or the hypovolemia or hypervolemia, but it's the cerebral perfusion pressure and the cerebral peripheral resistance. Of course, if we are in the range that we consider safe for the cerebral autoregulation. So for example, hypervolemia, that's the reason why hypervolemia under these conditions, so when cerebral autoregulation is preserved, will not increase cerebral blood flow nor contract vasospasm in this group of patients. So the choice of the fluids for severe patients with brain injury should aim to three priorities. The first one is to preserve and to optimize the cerebral perfusion. The second one is to control the brain volume and eventually reduce the brain volume. And the third one is to ensure an appropriate substrate delivery, an energetic substrate. So let's talk about the first point, maintaining cerebral perfusion, which means basically to provide hemoglobin, oxygen, and appropriate volemia and an appropriate blood pressure to the brain. And we're going to discuss the three different points regarding their role in maintaining the cerebral perfusion. Regarding the hemoglobin, the problem is that we don't have strong evidence on which is the best target of hemoglobin. We know that in general ICU, now we tend to be more restrictive regarding the targets of hemoglobin, but the target in neurocritical care is not completely understood. This is a randomized control trial which was published on JAMA, and patients were randomized to 10 versus 7 gram per deciliter of hemoglobin, and this is the neurological outcome. And as you can see here, there are not important difference in terms of vegetative status or mortality. And if we look at the Kaplan-Meier, so the survival proportion of comparing the transfusion threshold of 7 and 10, the log 10 says that there is no difference among the two groups. Now, there are really few evidence, and I'm going to show you just this systematic review. And as you can see, even if it's from 80 years ago, but there isn't much more since there. The authors found just 6 studies regarding and comparing lower and higher hemoglobin. And as you can see here, 5 of them are related basically to the higher and the lower levels of hemoglobin comparing mortality, and the others were about the length of stay. But as you can see here, the results were basically inconclusive in most of these studies. Now, the European Society of Intensive Care, thanks to Professor Fabio Lattaccone to Bruxelles, are leading a big randomized control trial on the level of hemoglobin, which is the TRAIN study, and we hope to have results soon. The other important factor is the volemia. In brain injured patients, maintaining an appropriate volemia is very important, and traditionally, especially in subarachnoidal hemorrhage, we have been told that hypervolemia must be maintained because it can improve cerebral blood flow and cerebral oxygenation. And then there was this study which was published a few years ago, which actually changed a bit the things. In fact, in this study, here there are patients who were neuromonitored at day 1, 3, and 7, and the differences in cerebral blood flow and in the cerebral oxygenation were obtained after the induction of only hypertension, hypertension and hypervolemia, and hypertension and hemodilution. So the 3H, the famous 3H. And what we can notice from this study is that regarding the cerebral blood flow, the triple H, but even only the hypertension alone, is able to increase the cerebral blood flow. But if we look at the cerebral oxygenation, the hypertension alone is statistically correlated with the increase and improvement of cerebral oxygenation. So it's because of this study that the concept of the triple H regarding the hemodilution and hypervolemia has led to a change in the 3H, which are now 1H, which is just the hypertension, and hypervolemia is not considered anymore a target in brain injured patients. But of course, what we need to be careful about is the control of the blood pressure. So again, it's not actually sure which is the best and optimal targets of blood pressure in brain injured patients, but we know for sure that if we keep them hypotensive, this will lead to a worse outcome. These are patients, this is a very important study, still famous, from Randall Chestnut from the USA. And as you can see here, there is a definitive increase of death and vegetative state when the patient experiences hypotension. And this effect is independent from age, the neurological status at admission, hypoxia, and extracranial trauma. So it's very, very powerful. So the first message is we have to target to normovolemia and avoid hypotension, target to normotension initially, and then there are some specific cases, like in case of vasospasm, etc., when we have to target to hypertension. Second point, we have to control the brain volume. I know that there will be a specific presentation regarding this, so I will go very quickly. So this is the draw that we have seen before with a healthy brain, and this is a damaged brain with a damage to the brain-blood barrier, where basically what happens is that the water and the electrolytes are able to pass through the brain-blood barrier, and the principle of the osmotic gradients are a bit deranged. So what do we do when we need to reduce the cerebral edema? So take the water and the water from the extravascular to the intraconvascular compartment. Well, we give basically osmotic therapy, and the options that we have are the use of a hypertonic saline and of a mannitol. Now, there is a lot of literature comparing both agents, and again, I'm not going into the details, but this is one of the study which compared the efficacy on ICP of the two, of hypertonic saline and mannitol, and they are able both to reduce intracranial pressure. So in terms of efficacy, they are basically the same. But we need to be careful when we use these drugs, because what we notice from this study from the Center TBI is that the use of osmotic therapy, and in particular with an increase of the sodium of over 150, is associated with a risk of acute kidney injury in traumatic brain injury. So they are useful, but attention should be paid to the side effects. And the third point is that what we need to do is to provide an appropriate delivery. So we know that the brain uses preferentially the glucose for his energetic metabolism and has a limited glycogen storage. So a continuous delivery of oxygen is necessary for the brain to work. And glucose enters into the brain through a mechanism of facilitated transport, and the brain extracellular concentration depends nearly on the plasma concentration. Now, I'm just going to mention that there are now new evidence and new studies which suggest the use of lactate or ketone therapies to fuel the brain, as this kind of therapy are basically able to increase the energy substrate and glucose sparing with an effect, with a beneficial effect on the ICP and cerebral blood flow. This is a bit more specific, and it's not the target of my presentation, but it's important to be mentioned. Let's move to the clinical applications. So I will start from the general use of fluids in neurocritical care. So which are the fluids that we have available? Normal saline, we have buffered solutions, human albumin of different concentration, and then as mentioned, the hyperosmolar solution, of which normally we use 20% mannitol and then different concentration of hypertonic saline. Now, the clinical trials in the general ICU critical care, which are mainly those that I present here, have found some initial interesting results. For example, they found no differences in mortality or acute kidney injury in patients treated with saline versus Plimalite. And for example, the SMART study published on New England Journal found that balanced solution resulted in a reduced mortality and reduced adverse events. This regards general ICU patients. The problem is that we cannot extrapolate to TBI these results because the representation of TBI patients or brain injured patients in these studies were very, very small. And as I described so far, the pathophysiology regarding the fluid management in brain injured patients is completely different. So we need specific trials. And the problem is that the evidence are not so big. So this is a systematic review which comes from the consensus of a neurointensive care group of ESICM, which has been published on ICM 2 years ago. And this is a systematic review regarding the studies which compare the type of fluids and their effect of outcome in brain injured patients. If we look at the two studies regarding the albumin versus saline, the first one, no differences in terms of neurological outcome, and the second one found a higher mortality in the albumin group. If we look at the study which compared balanced crystalloids versus saline, there is a tendency to the fact that the balanced solution reduced the rate of hyperchloremia, but this study has been methodologically criticized a lot. And then regarding the use of hypertonic saline as resuscitation fluid in the initial phase of a brain injury, so not for ICP control, comparable GOSE neurological outcome, comparable mortality, but with the possible side effects that we discussed before. And if we look at what is the clinical practice, this is an international cross-sectional study where basically the authors have assessed the patterns and the type of fluids which are used in adult intensive care, starting from 2007 and 2014. And these are basically, as you can see here, there are important differences from the use of crystalloids and colloids from 2007 and 2014. There is a definitive increase in the use of the crystalloids, with also an increased use of a balanced solution versus the saline. And there is a definitely reduced use of the colloids, and if I use, the only one which is used is basically the albumin, and the gelatin and the S are basically not used anymore in intensive care. And these are the results of few years later, and this confirms again this trend with an important reduction, nearly an elimination of the colloids from the clinical practice. So these are the recommendations of the European Society regarding the type and use of fluids in brain injured patients in the resuscitation phase. So they recommend the crystalloids as for the resuscitation and for the maintenance fluids in your intensive care, and they recommend against the use of colloids, glucose containing hypotonic saline, etc. And they also recommend against the use of albumin as a resuscitation fluid in neurointensive care because of the results of the previous study that I showed you before. And here there are some recommendations regarding avoidance of hypertonic saline solution as a resuscitation in neurointensive care patients and how to target the fluid management. For example, using a multimodal approach, using goal-directed therapy, and against, in neurointensive care, the use of restricted fluid strategies. As we know, and we discussed before, that what we are aiming in brain injured patient is an appropriate cerebral perfusion pressure. So regarding the type of fluids used to reduce the intracranial pressure, these are basically the evidence. And as I mentioned before, studies comparing hypertonic versus mannitol did not show basically definitive differences in terms of efficacy. And therefore the recommendations are saying that we suggest the use of mannitol of hypertonic saline to reduce ICP, so not for resuscitation, but to reduce ICP. We're not sure, they're not sure regarding which one of the two is best. Consider obviously the side effects of each one of these drugs and when to use it, when there is an increased intracranial pressure. Defining the threshold is difficult, but the threshold above 25 millimeters of mercury is generally used, and obviously monitor for the side effects, sodium, osmolarities, and the electrolytes to limit the side effects of osmotic therapy. And finally, the last point, the last clinical application that I would like to discuss is the fluid therapy for the management of the results of a systematic review, still from European Society of Intensive Care. And these are the trials which are available in subarachnoidal hemorrhage and acute ischemic stroke, comparing different strategies of fluids therapy. And as you can see here in the results, there are not differences in terms of neurological outcome. So what the authors suggest is basically to use a multimodal approach, avoid hypervolemia, use hypertension if there is vasospasm, and to target the increase of intracranial pressure and fluid administration on neuromonitoring, on clinical evaluation, and on the use of transcranial Doppler velocities, which is telling us whether there is an improvement of a cerebral perfusion. But these are recommendations which are just regarding the neurological targets. What about the hemodynamic targets? Unfortunately, even in this case, there are not evidence. These are the guidelines regarding the subarachnoidal hemorrhage management. And as you can see here, there are not so definitive recommendations. The experts are just telling us to avoid the routine use of Svangans and not to use the cerebral venous pressure to target the fluids, but no input, no information are available regarding the evaluation and the monitoring of the volume status and the hemodynamic monitoring. So in this systematic review and meta-analysis from my group, we try to summarize the evidence, and as you can see here, there are no evidence at all regarding the use of no monitoring or advanced hemodynamic monitoring. It's impossible to jump to conclusion from just these 3 studies and a meta-analysis with just few studies. But if we want to believe in this result, there is a possible beneficial effect on the development of vasospasm and DCI if we use an advanced hemodynamic monitor. And the clinical suggestion that I can give you is that the decision to put an hemodynamic monitoring together with a neurological one should be related to the clinical status of the patients, the cardiological complications, the presence of troponin, altered cardiac echography, clinical findings, and the entity of respiratory failure. So in conclusions, the targets of fluid therapy in neurocritical care is basically to maintain normotension and normovelia, to guarantee an appropriate energetic substrate. Which ones do we use? The crystalloids are still the first choice for the resuscitation, and avoid hypotonic solution, colloids and albumin, but also avoid hypertonic and osmotic therapy in the phase of resuscitation, but consider it to reduce intracranial pressure during using an ICP monitoring. It's important, and it's also a bit difficult to find the balance between the hemodynamic and the brain needs, which sometimes do not go together. And therefore, what I suggest you is to use hemodynamic and neurological monitoring. Thank you very much for your attention.